Hello, everyone. Thank you for joining the Scleroderma Foundation Rocky Mountain Chapter's virtual university. This session is titled GI Manifestations of Scleroderma. My name is Cindy Besseliever, and I am a member of the Scleroderma Foundation Rocky Mountain Chapter and National Board. Before we get started, just a few quick notes about this session. If you would like to ask a question, please use the chat function. And we will be moderating those throughout and keep the questions until the end, but please type them in as you come up with your questions. We will also be sharing links during the session via the chat, so be sure to check in there occasionally. A live Spanish translation is available for this session via phone, and we will also post that in the chat and on our chapter website. This session is being recorded and will be shared after the broadcast. Just the Scleroderma Foundation's disclaimer, this foundation no way endorses any clinical trials, treatments, or studies mentioned in this session. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with your individual doctor. This webinar is for educational purposes only. I would like to introduce Dr. Robert Reveille, who is our presenter this morning. Dr. Reveille is an Associate Professor of Medicine at CU School of Medicine and is the Chief of GI and Hepatology at the VA. He completed his medical residency and GI fellowship at the University of Colorado from 1984 to 1990 and served on the faculty until 1992. After 23 years in private practice, he rejoined the faculty in 2016. He is a regional expert on GI motility disorders, serves as an educational consultant in GI motility for Diversitech Sandhill Scientific in Littleton, Colorado, as well as on an international research panel for disorders and anorectal physiology. Welcome, Dr. Reveille, and thank you for joining us this morning.
Good morning, Cindy. Good morning, audience. Happy fall. I think fall has finally arrived here in Colorado. The interest in motility stems way back in fellowship, and I've done a lot of work over the years. One of the most difficult organ systems that goes wrong in folks with scleroderma is the gastrointestinal system. I see from the interest in this morning's seminar that perhaps when the gut doesn't work right, it's really hard to manage your day, and we've cared for lots of folks over the years who have GI manifestations of scleroderma. While this is somewhat of a didactic talk and it's an overview of how the gastrointestinal system can be adversely affected in scleroderma, it is not completely inclusive and it is not in great detail because I would like to offer the opportunity for a good question and answer session. So let's take it from the top. You know, scleroderma, systemic sclerosis, is characterized by connective tissue disorder with thickening, scarring of the skin, and also visceral involvement of organs such as the heart, the lungs, the kidneys, and in my world, the gastrointestinal tract. Now, you may or may not have gastrointestinal symptoms as you listen to this seminar this morning. However, I would point out that with progressive disease, nearly 90% of patients with scleroderma will have some degree of GI involvement. And we can often measure abnormalities in the motor function of the gut long before symptoms surface and you would present them to your physician. Now, the basis of the injury to the GI tract is related to loss of the smooth muscle. There are two columns of smooth muscle, unlike your skeletal muscle or your heart muscle. It's a unique type of muscle that invests the entire GI tract from the throat to the anus. And the smooth muscle moves very slowly but very rhythmically to produce peristalsis. As these muscles degenerate and they fade, they're replaced with scar tissue, the same scarring that is occurring underneath the skin and in other organs. Eventually, that smooth muscle is choked out of the picture and there's complete loss of function and the gut becomes simply a hollow scarred tube. Now, why is this pathogenesis important in the GI tract? Well, unfortunately, as we pointed out, the GI tract has smooth muscle from top to bottom. On the left is just an anatomic diagram of the stomach. There's a circular muscle coat, And around that, there's a longitudinal muscle coat. And this is how the smooth muscle generates peristalsis throughout the gastrointestinal system. It should be said that scleroderma typically starts with the esophagus, but as time progresses, it has the potential to literally work its way down the entire gastrointestinal system and all the way to and including the anal sphincter. So the presentations for scleroderma, gastroesophageal reflux, which is already a common disorder in our population, is extraordinarily common in patients with scleroderma. The lower esophageal sphincter is a specialized area of smooth muscle that develops fibrosis and atrophy, and what used to be a one-way check valve to prevent reflux of gastric contents becomes a wide-open two-lane highway. For those of you who are suffering from a reflux disease in this situation, you know that it's often difficult to manage. Other symptoms include dyspepsia or bloating, early satiety because the gastric wall develops scarring and the stomach cannot stretch to take in the incoming food volume. Therefore, you feel fuller at an earlier point in the meal. On the other hand, gastric emptying is also promoted by smooth muscle. And as the muscle becomes scarred, then the power to push that food from the stomach and move it down the digestive tract becomes quite inhibited. And this is a situation we call gastroparesis. As this disorder moves down the small intestine, the small bowel is responsible for moving the digestive chyme and using it for absorption of all the micronutrients, the glucoses, the sugars, the proteins, amino acids, the fats, fatty acids, and cholesterol. And if there is stasis or lack of peristalsis in a segment of the small bowel, you may have problems with something we call pseudoobstruction. And another condition which you may be familiar with is SIBO, or small intestinal bacterial overgrowth. Imagine the small bowel as being a river, and if you follow a course of a river, there are new parts of the river where the water is moving swiftly through the canyon. There are mature parts of the river where the flow is very constant. And then there are old parts of the river where there is stasis, there's pooling. And in fact, think about that's often where fish will populate, because that's where they can reproduce at high numbers without being swept away by the current. Imagine, therefore, that the fish are actually the bacteria in your intestine, and in an area which is old and not moving, those areas have bacterial buildup, which, and in that case, the bacteria compete for your nutrients. You'll hear later today about nutritional management, which is critical to managing the GI manifestations of scleroderma on the small intestine. At the very bottom end, patients often have fecal incontinence. Scarring of the internal sphincter will also lead to loss of control, passive or active seepage, or the inability to control an urgent bowel movement. And the overall picture here, the most important thing about all of this is if there's any dysfunction along the GI tract, malnutrition can be a consequence. So what's the normal function of the smooth muscle? When we ingest food, the smooth muscle is designed to propel the food and participate in moving things down to the digestive components of the intestinal tract. It's not one hollow tube with a single function. In fact, the small bowel has multiple specialized areas that do certain things, like absorbing of iron and calcium from the upper part and absorbing B12 from the lower part of the small intestine. So here's an example of what peristalsis is in the esophagus. In this case, there's a food bolus, and as the bolus is swallowed, the smooth muscle beyond the bolus relaxes, and at the same time, just above, there's a contraction, and this contraction then moves in a nice sequential fashion and propels that bolus down to the stomach. So that's the normal peristaltic function throughout the entire gastrointestinal system. With regards to the esophageal symptoms, 40 to 50% of folks with established scleroderma have heartburn and may have difficulty swallowing, a term we call dysphagia. Measurably, if I do a manometry test on a patient with scleroderma, up to 90% of individuals will have impaired motor function even though they may not yet have symptoms. So smooth muscle dysfunction can also impair the lower esophageal sphincter and leading to reflux disease. The other thing that happens with the esophagus and scleroderma is almost unique to this condition. When you swallow a bolus of food, there's a primary wave that strips that bolus down to the stomach. If there are any contents remaining behind in the esophagus normally knows to generate a secondary peristaltic wave and clear that esophagus of that ingestion that you just took in. Unique to scleroderma is the fact that one of the early findings is loss of that secondary peristaltic wave, that secondary clearance to keep your esophagus clean after swallowing liquids, pills, or solids. Two main factors related to esophageal motility: impaired motility and dysphagia, weakened clearance. As I said, secondary peristalsis that fails to clear the residual content can result in yeast infections in the esophagus, principally. And this issue about a loss of LES function, lower esophageal sphincter, and reflux. We try not to do anti-reflux surgery on patients with scleroderma, although it can be done, because to tighten the lower esophageal sphincter surgically means that the upstream motor function will be unable to swallow anything, and you wake up from surgery being completely obstructed, and that's not a good outcome. So I'll give you a little science lesson here. This is the esophagus under the conditions of what we call normal motility. This is a color contour plot. As the color increases to red, brown, and pink, that's evidence of an increasing pressure profile, and this is a normal swallow. Here, the swallow is started at the throat. The esophagus normally relaxes and waits for the water or the bolus to come through, and the peristaltic wave rides this bolus down. In scleroderma, you can see what happened. Well, your brain said, let's get a swallow. Your throat said, let's get a swallow. And the esophagus was unable to generate a peristaltic wave. This is the hallmark of what we term the scleroderma esophagus, although this pattern can be seen in other connective tissue disorders. So how do you fix this? Well, there aren't any good medical treatments to deal with muscle dysfunction when the muscle is atrophied or lost. It's important, if you have a new complaint of dysphagia, to seek gastrointestinal help. An endoscopy may be indicated because acid reflux does cause scarring in and of its own, and scarring can result in narrowing or a stricture. And strictures can be dilated during an endoscopy to improve overall swallowing capability. For heartburn and regurgitation, I think you're all aware of all the now over-the-counter acid reducers. This is the proton pump inhibitor group, which reduces stomach acid production by 70 to 90%, up to 16 hours after a single dose. Although many patients with scleroderma find that nighttime acid is still a problem, and therefore they have to take this medication before breakfast and before dinner. Most importantly, the late night, avoid the late meals. Anybody with reflux disease should avoid eating within 4 hours of recumbency, and that goes for scleroderma as well. What about the stomach? Let's move on down the GI tract. We talked about the loss of stretch function, that is feeling full earlier than you used to, and also the ability not to empty the food. Bloating, nausea. One of the classic symptoms of gastroparesis is a patient will have their meals throughout the day. They won't feel full by dinner. And the next morning, the first thing that happens is they have vomiting and they realize that they have undigested food from the night before. That kind of symptom should prompt an evaluation for gastroparesis. Most of the time, the treatment is dietary and sometimes medically to try to stimulate the residual muscle that has not been lost during the scleroderma process. Now, you know your heart has a pacemaker that runs your heartbeat at 60 times and 100 times a minute. Well, it turns out that your stomach has a pacemaker. Right along the greater curve of the stomach, there is a collection of cells that normally generate contraction waves to grind your food once it's been ingested. You don't feel this contraction because the stomach contracts at a rate of 3 to 5 beats a minute, unlike your heart. So it's something well below our conscious awareness. Treatment options for gastroparesis would include small, frequent meals. It's the grazing type of dietary behavior, not the have a bagel for breakfast, skip your lunch, and have a big meal for dinner. That's a no-no for all of us, and particularly in patients who have established gastroparesis. Low fat. Now, why do I say low fat? Fat normally releases a hormone that slows the rate of emptying in all of us. If you have established gastroparesis and you have a fatty meal, that may delay the stomach for up to 4 to 8 hours before food is finally emptied. So if you have gastroparesis, low fat, small volume meals are appropriate. And I tell people to try to avoid roughage. That is things that the stomach doesn't really digest, like salad. Salad is not something that the human body can digest very well. It's great for roughage for the bowel, but it's at a great expense of excess work on the stomach. Lactose-free, Protein supplements are often helpful to maintain weight or to regain weight. If we try to stimulate the stomach, keeping in mind that we're up against time and a progressive scarring process, the medications we've used over the years include metoclopramide, domperidone, which you have to get a special permission for in the United States, or we can send you to Canada or Mexico. Erythromycin, now you know that as an antibiotic, but in my world, erythromycin binds to a receptor called motility in the stomach, and 4 hours after you ingest food, motility normally kicks in as a garbage sweeper, if you will, to empty the stomach of residual contents. We can trick the stomach into generating forceful emptying contractions by using erythromycin or erythromycin analogs. Other medications that have been out on the market but have been pulled back due to FDA concern include tigacerod, prucalopride, which is also used for slow constipation, and clebupride, which will be available, if not already, it's been FDA approved. We have evidence for prucalopride and clebupride in the colon, and we have some evidence for prucalopride benefiting patients with gastroparesis, but it's often difficult to get insurance approval for that indication. Desperately and unfortunately, sometimes the stomach is so damaged in terms of function that we have to place a feeding tube, a gastrostomy or jejunostomy to provide appropriate protein calorie supplementation. And I've not had to do this in quite some time, but sometimes people have to be resided to intravenous long-term feeding called total parenteral nutrition. Now, the small intestine is really the main peristaltic component of the digestive system that allows you to actually absorb your nutrients. Mechanical breakdown is accomplished by the stomach. Chemical breakdown is then taken care of by the upper small intestine, and then the small intestine absorbs all the basic components of our foods. Between meals, there's a motor pattern also that allows us to pass things such as salad down to the colon and creation of waste for the next day. So the small intestine becomes extremely important in the overall nutritional health of all of us, and we need to be very attentive as physicians to asking about and doing nutritional assessments on patients with scleroderma. Now, a little bit more science for a minute. If I place a motility catheter in the small intestine of a human and I feed them, this pattern is a normal and very organized pattern. This control patient is in the center. This is a normal pattern of eating and contractions of the small intestine, moving the food down toward the colon. As a corollary, diabetes patients often have a neuropathy, that is damage to the nerves that regulate bowel function, and they have disordered or loss of correct function. So you see there's nothing, they're just intermittent irregular bursts of activity, and it doesn't really make sense, and it doesn't pass food down to the colon and complete the digestive process. On the left hand is a patient with scleroderma. The contractions are frequent, but you can see that the spikes are not very high. That is, the amplitude or the power of contractions has been lost. And think about it again. It's smooth muscle that's been encased in a core of scar tissue. So it's at a mechanical disadvantage. And this is the kind of pattern that we sometimes see. Fortunately, in modern medicine, we rarely have to resign ourselves to asking a patient to undergo small intestinal manometry. It's a very unpleasant test. So the consequences of small bowel maldigestion and loss of peristalsis. Remember the river concept here. If there are areas of the small intestine that are very slow and sluggish, and the upstream small bowel is still working well, then we have areas of pooling of small bowel bacteria. And as bacteria grow, and I'll use an example, this is not an absolute number. Let's say, for example, that in every milliliter of fluid in your small bowel, you have 1 million bacteria. And that's a normal healthy balance between you and the bacteria, the so-called good bacteria. Now we have an area where the bowel is no longer peristaltic. We have old man river. Now the bacteria grow from 1 million to 10 million or 100 million bacteria per ml of fluid. It's at that point that the bacteria compete with you for all the nutrients you took in with that previous meal. They rob and steal and leave nothing left over for the human for absorption and maintenance of health. One of the other complaints that patients complain of actually is the issue about, I have a jumping jumpy mouse here this morning. Must be the cats. Is bloating. Bloating is a difficult symptom to try to pin down, but in scleroderma patients, bloating to me means we've got problems with motor function in the small intestine, and particularly the issue about slow, sluggish flow, bacterial overgrowth, and this potential for something we call intestinal pseudo-obstruction. It looks just like a mechanical bowel obstruction on x-ray, and the only way you can discern that is by a proper history and occasionally doing x-ray studies. The treatment of small bowel bacterial overgrowth is actually not that difficult. I work with folks and we place them on broad spectrum, gut-specific antibiotics. We do cycles of 2 to 3 weeks at a time, followed by 3 to 4 weeks of a probiotic. And then we find another antibacterial and switch to that one. We always want to keep the bacteria on the run. If you use the same antibiotic again and again and again, you'll develop resistance and you'll not accomplish the goal of managing bacterial overgrowth and restoring your normal food absorption and normal overall health. The other thing we can use is something called octreotide. It is a synthetic version of a hormone that regulates small bowel motor function. And octreotide, given as an injection under the skin several times a day, may restore normal motor function, at least early in the small bowel course of scleroderma involvement. We don't pay much attention to the colon except when it's not working. And in this case, one of the biggest problems that we see is what we call slow transit constipation, leading to something we call inertia. Absolute standstill of the colon as the waste enters the colon and moves across the abdomen to be deposited next day's bowel movement. Lots of medications have been used. Laxatives may be helpful if the small bowel is not involved and you don't have small bowel overgrowth diarrhea. Stimulants, the most potent stimulant that we have for promoting colonic motor function is something that you're very well aware of, Dopalax or bisacodyl. And it's the only medicine that directly stimulates smooth muscle. Everything else we do is an irritant to the colon or makes the colon secrete water when it's supposed to be an absorbing organ. So bisacodyl, sometimes at very pronounced doses, 20 milligrams a day, 20 milligrams twice a day, may be necessary to make that colon work in the setting of scleroderma involvement. In addition, some of the newer agents that have come on the market include linaclotide, lubiprostone, and prucalopride. All of those work by making the colon secrete sodium and chloride and water, making the stool loose enough so that it can pass and not require much motor function to move it from the cecum to the rectum. The sigmoid colon is your reservoir. I call it your organ of social convenience. When you decide or you feel as though you have to have a bowel movement, you often will retain that by contracting your pelvic floor, and the waste will move back into the sigmoid colon and wait for the next appropriate time. The sigmoid colon, believe it or not, goes backwards 50% of the time throughout the day. It is the brake, B-R-A-K-E, for the entire colon and waste excretory system. So as we contract our anal sphincters, waste that's entered to the rectum will move back to the sigmoid colon and will stay. The rectum can be involved with scleroderma, and that's really how you push out your waste. If the rectum becomes scarred, you may have a sense of incomplete evacuation and excessive straining just to get a small amount of waste into the toilet. So we are very attentive to changes in the rectal wall when we study this area in patients with scleroderma. The internal anal sphincter is 100% smooth muscle, and as it becomes scarred, it loses its contractile capability, and therefore not only can you have difficulty with elimination, but you can have difficulty just holding back a bowel movement. And if there's any liquid residue in the stool or gas that you had not intended to release, it may come out before you know it. There are three main mechanisms that control the bowel. With respect to the sphincter, the pelvic floor muscles are very critical to maintaining proper anatomy. We are 3D upright animals. Therefore, gravity, as you know, is often our worst enemy. And in this situation, we want to have a sphincter that is tightly closed until it's time that we voluntarily eliminate our bowels. The internal sphincter comprises the majority of that closure, and the external sphincter, and believe it or not, your hemorrhoidal tissues. The hemorrhoidal tissues are not there just to cause trouble. They're there to bring closure and create a tight seal at the anus as we're up and about during the day with activity. Fibrosis of that muscles there leads to loss of stretch, loss of distension, that is less capacity. You may notice that you feel like you have to go to the bathroom much more frequently and much more urgently than you did prior to involvement with scleroderma. Interestingly, the treatment for fecal incontinence has to do with sometimes something we call biofeedback to strengthen those muscles, and a classic antidiarrheal called Imodium or loperamide. That drug, you know, is an antidiarrheal, but in my circle, I know that is the only drug that we have to date that can be taken orally that can enhance the internal sphincter contraction for about 4 hours. So if you're worried about having an accident in public, what you can do is take a half a milligram or milligram of Imodium before your outing, and you can pretty much have confidence for about 4 hours in the public setting. So where are we at with scleroderma in the GI tract? Well, I think if the gut isn't working and you have scleroderma, then it's going to be a very difficult day, and we're very sympathetic to this. You may have minor symptoms or you may have no symptoms at this time, which I think is a great thing. But we know as a consequence of the scarring prosthesis occurring in the skin, in the other organs, that the GI tract is frequently involved and the disorder moves from top to bottom. Literally every segment of the GI tract can become involved, leading to loss of function and development of symptoms. When the GI tract is involved, the esophagus is frequently involved, even in an asymptomatic setting, and the disease, if it's going to progress, and I'm not here to tell you that it does, because it almost always starts in the esophagus, it may not go beyond that. And if that is the case and it stays there, then that's very fortunate. But should you be an individual where the entire GI tract is slowly but surely being involved with the scarring process and loss of function, know that it begins at the top and it can end all the way at the bottom. Now, we have specific testing for several areas. We do esophageal manometry, as I showed you on the earlier slide of function. That's an easy test to do. I've done it on myself. You won't want to do it more than once, but it is something that you can get through in about 15 minutes. We can measure gastric emptying. The way we do that is we give you a radioactive medicine placed in scrambled eggs, and you sit in front of basically a computerized Geiger counter, and that will measure the rate of emptying of your stomach. And there are very well-defined cutoffs between normal emptying of a scrambled egg meal and abnormal emptying. An abnormal delay is a diagnosis of gastroparesis, and that prompts a dietary medication pathway that I talked to you about earlier. With the small bowel, we don't normally measure small bowel motility, but the one thing we can measure is small intestinal bacterial overgrowth. It's something called a hydrogen breath test or a methane breath test, where you're given a medication that, as it's digested in the small bowel, it releases radioactive hydrogen, which you breathe then into a detector, and there's a very well-established range of normals for when the peaks occur after the ingestion of the test meal. So SIBO can be tested and measured directly, and it's an indication to go on with these cycle courses of antibiotics, as I alluded to. The colon can be measured with its motility using something called a smart pill capsule. That actually will measure the motor function and the time the pill takes in the small bowel and the colon to give us an idea about whether the colon in fact has become inert and not moving at all. The anal sphincter and rectum can also be examined through something called anorectal manometry, which is a catheter-based test with the balloon that's placed in the rectum for about 15 minutes to measure the rectal wall compliance, measure the sphincter tone, and measure your ability to squeeze on command to see whether there's something that can be done in terms of physical therapy. So we have options from the top to the bottom for testing, and we have, as you can see, an expanding number of options for enhancement of motor dysfunction that occurs in the setting of scleroderma. Now, it's important, this is my last take-home point, it's very important to report any GI symptoms early in the game. Management early in the game preserves function for a longer period than if we get to the end stage of dysfunction related to scleroderma involvement in the GI tract. And since medications are now available and we have a few new motility agents on the horizon, the the future is a lot brighter than it used to be with regards to GI tract involvement with the scleroderma. Last but not least, we want to avoid the complications. We don't want to do unnecessary surgery for a pseudo-obstruction. We'd like to avoid a gastrostomy tube. And as you'll hear later today, we don't want to become malnourished. Malnourishment is not a great thing for any management of any disease state. And in scleroderma, maintaining health and nutrition is very, very important. So I'd be happy to take any questions that you might have about this general overview for scleroderma and the GI tract.
Thank you, Dr. Reveille. We did have a couple of questions come in. The first one is, sometimes in the middle of the night, I wake up coughing and choking and can barely breathe. It feels like there is acid from my stomach getting into my lungs. It is super scary as I gasp for air. Is it possible for me not to be able to breathe?
Well, you're definitely having acid reflux into your lungs at nighttime. And having had that happen after a late night chocolate meal with red wine and coffee, waking up at 2 in the morning with acid in my throat, this is an extremely scary event. Acid on the vocal cords and that cough that you described, those are things that really should be brought to the attention of a physician, because you may have not just acid reflux, you may have gastroparesis. So not only bringing acid, but you could bring up food and bacteria that is stayed in your stomach. That's a setup for pneumonia. And for patients with scleroderma who have lung fibrosis, lung scarring, one of the things that we routinely do now is we do 24-hour acid monitoring to look for reflux, because that needs to be managed aggressively if we're to halt the progression of the scarring process in the lungs of a scleroderma patient. You shouldn't eat within 4 hours of going to bed. You should be on an acid reducer before breakfast and before dinner. I would also suggest an over-the-counter famotidine type medication for bedtime acid control. Head of the bed up, perhaps on 6-inch blocks or a wedge pillow, so that at no point do you have a disadvantage where there's retained stomach acid in the stomach that goes through a weak sphincter and ends up in your lungs. Now, that's a very scary process. I'm sorry you've ever experienced it, but having had that firsthand, yeah, I would aggressively manage that and try to prevent that from occurring going forward.
Great, thank you. Next question, is silent reflux common in scleroderma?
Yes. In addition to silent dysmotility, silent reflux is actually probably more common in a scleroderma patient who has esophageal involvement than in any other group that I can think of. And that should be thought about early in the game if somebody has any signs of reflux or esophageal dysmotility. I don't want you to go have tests unnecessarily, but on the other hand, you know, there's been a lot of bad press about the PPI group of acid therapies. Many of these pretended bad outcomes and complications they've not borne out in the literature. But I think there are a few about long-term acid control that we shouldn't just shoot from the hip and throw everybody on an omeprazole or a Prevacid or anything like that without a detailed history and perhaps going the extra mile and actually doing the testing for silent reflux.
Great, thank you. What do you recommend for a good night snack for a person with acid reflux?
No snack after 8 p.m., that's for sure. Although something that's a simple carbohydrate like crackers or bread, just to absorb excess fluid in the stomach at nighttime may be appropriate. I would please not do anything fatty. Large volume snacks should be out of the question, and I might avoid citrus fruits as well. Especially things with pulp, take a long time for the stomach to empty, akin to the lettuce thing that we talked about, the roughage. Peanut butter, probably a little bit fatty in a scleroderma patient who has gastroparesis, but I do like the cracker idea, and I would probably do it no closer than 2 hours before I put my head on the pillow.
Another question, is nausea common as a symptom?
Nausea is common as a symptom of gastroparesis, and nausea is a common and often overlooked symptom for people who actually have reflux esophagitis. They just don't have acid reflux. They actually have esophageal inflammation. So nausea throughout the day, nausea that gets worse at night, esophagitis and gastroparesis need to be evaluated early in the game.
Okay, now they're coming in quickly. Can you talk more about the cyclical antibiotics, and when is it decided that that route would be beneficial?
Well, I'd like to hear from a patient that the symptoms they're having are bloating and diarrhea, and they're not maintaining their weight. That to me suggests that the small bowel is in fact involved with the scleroderma process. The antibiotics, obviously, the first thing we start with is making sure you don't have any antibiotic allergies. One of the hallmarks is a broad-spectrum penicillin. Believe it or not, good old-fashioned tetracycline has been an excellent treatment for SIBO for decades. The disadvantage of that drug is if it gets stuck in your esophagus, it can cause an ulcer. And so tetracycline can be tricky in patients who have advanced esophageal motor problems as well. We were relying on the quinolones such as Cipro for a long time, but there's been some adverse events with Cipro and related drugs in terms of heart manifestations and cardiac abnormalities, so we try not to do that. It also does affect the collagen in your tendons. So that class of drugs has basically been taken off of our routine list. One of the medications we've used over the years is metronidazole, which tends to go after the bacteria that do not require oxygen in the bowel. They're called the anaerobic bacteria. It's a great medication. However, 30% of people can't tolerate it because of nausea. So if you're already nauseated, that's not a good thing. And the fact that it causes a really odd metallic taste as if you're chewing on rusty nails while you're taking it. So it's a difficult drug to take for many people because of those side effects. In addition, you can't take that medication and have any alcohol ingestion in the body because there's a chemical reaction that can occur in patients taking metronidazole who have even a small glass of wine. So we have what I counsel patients with. Let's create a library. When we first embark on bacterial overgrowth treatment, it is somewhat you're going to be your own experiment along with your physician. So we're going to start with something, maybe a broad spectrum penicillin if you're not allergic. We're going to do that for 2 to 3 weeks, and then we're going to give you a break. And then we're going to use a probiotic. And I'm sure there will be a question about what probiotic do you recommend. Keeping in mind that most of the literature on probiotics is not very robust, but it makes sense to me if I'm going to take out many of the good bacteria, reduce the pools of excess overgrowth, reduce gas bloating, and increase nutrient absorption, then I want to be able to roll over to another drug, and I want to restore good bacteria before I go on to the next antibiotic. So a broad spectrum penicillin, 3 weeks, 4 weeks on a probiotic, then 3 weeks on the next. And I create 2 or 3 of a panel for each individual that seem to work and really get their symptoms down to a dull roar or completely abolished. And then once we do that, we keep going. And at the end of 6 months, many people say that they found they can go much longer between antibiotic cycles. So perhaps we're doing something, the antibiotic is actually every 8 weeks or every 12 weeks. They need just little bits now and then to keep the digestive balance of bacteria in a tolerable range, keep up the nutrition, keep the bloating, etc., down to minimum. So each of you would be your own experiment with your physician. What works, what doesn't, and are you having any side effects, rashes, etc., with any of the selections on the antibiotic profile?
Great, thank you. Next question. What is a hiatal hernia?
That's a wonderful question because the term is very arcane. Normally, your stomach and your esophagus join right at the level of your breathing muscle or your diaphragm. The esophagus passes through a hiatus or an opening in your diaphragm to connect to the stomach. When that opening begins to enlarge, then the stomach actually begins to push itself up through the diaphragm and into your chest. And that is what we call the hiatus or hiatal hernia. You do not have to have a hiatal hernia to have acid reflux, but on the other hand, most patients with a hiatal hernia will have acid reflux as the hernia enlarges, because it turns out not only is your lower esophageal sphincter, that smooth muscle ring, important as a barrier for reflux, but there are muscles around the diaphragm called the crura, and they hold that esophagus in proper position in that stomach below the diaphragm. Those muscles get loose over time as well. So as the diaphragm opens, the crura portion of the diaphragm loosens, and now you've lost all sphincter function. It's a two-lane highway because of the hiatal hernia.
Thank you. Can you speak briefly about Barrett's esophagus?
Sure. One of the long-term potential consequences of acid reflux, acid damage to the skin of your esophagus, is that the tissues can undergo a change, and this is a change under the microscope. It goes from a nice soft pink white color, just like the inside of your cheek, and it develops a very what we call salmon red appearance as it comes up from the stomach junction, and this is called Barrett's esophagus. It actually looks under the microscope like somebody's put a piece of small intestine between your esophagus and stomach. Under the microscope, it really has a lining pattern that looks like small intestine. We call it intestinal metaplasia. Now, what's the big deal? Well, many of us may have a little bit of Barrett's esophagus after chronic reflux, but a very short area does not change your future risk of esophageal cancer. However, we know that adenocarcinoma of the esophagus most often arises from chronically irritated tissues in the Barrett's area. So Barrett's esophagus has been termed a potentially precancerous change in the esophagus due to long-standing acid reflux that wasn't well controlled. Now, not to alarm anybody, but if you're a new onset heartburn patient and you have scleroderma, the chance that you have Barrett's is very small. Barrett's esophagus is felt not to develop in most patients until after 10 years of acid reflux. And the classic pattern was a middle-aged white male smoker with a waist circumference of greater than 38 inches with a BMI of greater than 30. That defines a rather rotund middle-aged white male smoker. Well, we're now starting to see, as we listen and we look, that other populations are at increased risk of Barrett's esophagus. We see Barrett's esophagus in scleroderma, but I must tell you, I have not seen a disproportionate number of patients with scleroderma who develop Barrett's esophagus. On the other hand, if you have it, you will have periodic endoscopies looking down there every 1 to 3 years with biopsies being taken to be sure that this Barrett's esophagus is stable and it does not have something we call dysplasia. That's an appearance under the microscope where the cells have been so damaged at the nuclear level, the DNA is disrupted, and there's a potential for cancer cells to begin to develop in that abnormal lining. But that takes a long time. That really takes quite a long time. If you have been diagnosed with Barrett's esophagus, you should be having periodic endoscopy. Just like after age 50, we often have to have periodic colonoscopies. If you're a polyp maker, you go and have a checkup on a regular basis to be sure you're not making new polyps, which may also be precancerous.
Thank you. Next question. After eating, I start with a lot of hiccups, belching, and chills. I take metoclopramide. Is there something else that can help me?
Well, it sounds like you may have a component of gastroparesis, and I'm guessing that you have been put on metoclopramide to try to help two things. Number one, help the lower esophageal sphincter, if at all possible. And number two, to get the gastric contents out of your stomach and downstream into the bowel. Hiccups, the number one cause of hiccups is acid reflux. And probably in this setting, the second most common cause would be distension of the stomach as it pushes up under the diaphragm, that actually it's irritating the diaphragm and causing the hiccup reflux. In addition to the metoclopramide, it might be appropriate to have something called Gaviscon, which creates a nice foam on top of the food. And that foam will actually be protective against, number one, acid reflux. And number two, it will tend to create a barrier and allow the food to move downstream and allow the metoclopramide to take effect. And it might also be time to consider either stopping the metoclopramide. The long-term side effect of this are symptoms that resemble Parkinson's disease. We're very careful nowadays to monitor patients every 6 months for any neurologic signs and symptoms that might be deemed a side effect of metoclopramide. So the other medicines I mentioned, such as erythromycin or tegaserod, may be worth the extra effort to get those and either add those to the metoclopramide or to replace them by the metoclopramide. I find that small doses of multiple, what we call the prokinetics, those things that promote the forward motility, are better tolerated and work better than pushing any single one of those drugs to the maximum dose, where the body will over time become resistant. We call that tachyphylaxis. You'll become resistant, the effect will be lost, and it may be the expense of serious side effects. So it's time to maybe think about having another medication put on board. And I like the Gaviscon idea after meals because it does add a protective foam. And you also get a little calcium in your diet, which is good.
Great, thank you. The next question is actually three-part. What is Hill GE flap valve? What is esophagitis stenosis stricture? And what is gastric fungus polyp?
Let's start with the first one again. Could you repeat that?
Hill GE flap valve.
Not sure what the first part was. Spell that?
Hill, H-I-L-L.
Oh, Hill. Thank you. Thank you. Professor Hill was a surgeon who, when we started doing endoscopy, described the 3D anatomic appearance of the lower esophageal sphincter. When we go into the stomach with our endoscopes, we can actually turn the scope backwards and look up underneath and look at the sphincter appearance. There are three normal configurations that describe the crural diaphragm and the lower esophageal sphincter. And there's actually an angle created by your diaphragm called the angle of His. And that angle, the surgeons have felt for decades, is critical to all of us not having acid reflux, particularly when we lie down. If the angle is acute, then gastric contents can't sneak up into the esophagus. If the angle is wide open, described as the higher Hill classifications, when you look at it, then the potential for reflux increases as the angle opens. So it's really an endoscopic description of the visible anatomic relationships of the sphincter valve in normal individuals, and as it gets looser over time in patients with acid reflux. Second question was esophagitis? Yes.
Esophagitis stenosis stricturi.
So esophagitis, if you hear the back part of the word, itis, itis, that means inflammation. Anywhere in the body, if you got itis, you got inflammation. And esophagitis, if we're looking in the esophagus in someone who has esophagitis, it's red, it's raw. It may have protein exudates, almost looking like material off of a fresh scab. It may even have ulcers, and those describe varying degrees of esophagitis. Now, the problem with the esophagus is it's a hollow tube. And if the response to inflammation is always putting scar tissue where the damage was, and a hollow tube, when you put scar tissue there over time, you can see the narrowing that's occurring as the scar tissue is forming. This describes stenosis or stricture, same term. And that's a result of acid damage being replaced by scar tissue in the hollow esophagus. It's the nature of the hollow tubes of the body. They always seem to scar and they narrow as they do that.
Great. And the last one was gastric fungus polyp.
When patients have been on acid reducers for an extended length of time, and this probably takes years as well, you know, the stomach is not stupid. The stomach is supposed to make acid to digest food. If you therefore block the ability of the stomach to make acid, it will release additional chemicals to try to tell the residual stomach tissues, hey, I need more acid. Well, one of the things that's a stimulus also causes the upper stomach, which is called the fundus, to grow the lining at a faster rate. Therefore, it stimulates this little polyps that develop, and fundus gland polyps really, unless you have 100 or more of them, don't portend any future risk. We see them often in patients who have acid reflux disease who've been on a proton pump inhibitor. And as I said, as long as you don't have 100 of them, we're not really worried that they have any cancer risk in the future. They're just a finding. Says you've been on acid reduction for a while.
Okay, great. Next question. Can you explain jackhammer esophagus?
Sure. It's actually almost the exact opposite of what we expect in most patients who develop esophageal dysfunction with scleroderma. jackhammer esophagus was a new designation for people that have not weak peristalsis or absence of peristalsis, but have in fact an extraordinarily high-powered contraction of the esophagus. And it can cause chest pain, it can cause trouble swallowing. Even though the food does move, it's a sensation that the food isn't moving because of the high-powered contraction. And in many patients, it's simply a finding that we see on manometry that has nothing to do with anybody's symptoms. But it's not the typical pattern we would expect in scleroderma as it involves the esophagus. So if someone has jackhammer esophagus, you can pretty much tell them that the esophagus is not yet involved with scleroderma.
Can you talk about, I think it's GAVE? G-A-V-E?
Yes, gastric antral vascular ectasia. This is an unusual thing that we often see in patients who have chronic renal disease, chronic liver disease, and may have other vascular complications, perhaps from the scleroderma. But GAVE is in the lower part of the stomach. That last third is called the antrum. Antrum means doorway, and that means doorway to the small intestine. It turns out that the antrum is the part of the stomach that does most of the grinding and contraction. It's the most commonly affected area from H. pylori, which you may know as a bacteria in the stomach that predisposes to ulcers, etc. But it's a source of chronic GI blood loss. Iron deficiency with somebody who does not have an occult colon cancer needs to be suspected as coming from the stomach. And one of the findings we see are these clusters of very superficial capillaries in these long linear arrays that run through the antrum, and they cause loss of blood over time. Generally not blood that you'd be aware of. It's just slowly draining the tank of the iron that's contained in blood, and then that goes down the digestive tract, fully digested, and you don't see any evidence of that in your stool. And that GAVE can be treated very, very effectively with something we call radiofrequency ablation. And the other thing we can use is something called argon plasma coagulation. But if you're having iron deficiency and GAVE has been felt to be the culprit, that can be corrected and gotten rid of by ablation with these endoscopic techniques.
Thank you. Questions keep coming in. Next one is, may the dilated esophagus return to normal?
Generally not. We call it the frozen lead pipe of the scleroderma esophagus. It normally will not return to normal once the scar tissue has set in.
Okay. Next question. You mentioned sleeping with your head up 6 inches. Does sleeping flat but on your left side perform the same function?
It performs a complementary function. I actually sleep on my left side because of my nighttime reflux. And so when you sleep on your left side, you increase the angle of His that we talked about. So that's critical for excluding the esophagus from having stomach contents go in. But you need to keep in mind that just because you start sleep left side down, I can assure you all night long, you don't sleep just left side down. We toss and turn and move all around. I'm sure you've seen videos of people as they sleep throughout the nighttime. Elevating the head of the bed adds another feature of gravity. Like I said earlier, gravity in general is not our best friend as we're upright human beings, but in the setting of nighttime acid reflux, gravity is our friend. And so it's not about putting yourself up on 2 pillows. It's literally about taking the head of the bed and getting a slant, or there are actually things called bedges, which is actually a wedge pillow that will prop your entire torso. You need to be upright at that angle from the waist up. If you bend yourself anywhere in the abdomen or chest just to get your head up, you're not going to accomplish the anti-reflux benefits of that angle and gravity's friend.
Okay, I think those are all of the questions. Thank you, Dr. Reveille, so much for your presentation today.
Fantastic. Thanks for the time.
Yep, thank you for your time and your expertise. Thank you all for joining us today, and a special thanks to our Diamond National sponsors, Actelion Pharmaceuticals and Boehringer Ingelheim. We would like to connect with you after this virtual conference. We offer multiple support groups each month, and you can connect in between meetings via phone or email. Our contact information is in the chat. Finally, if you like this event and want to see more, please connect with the Scleroderma Foundation Rocky Mountain chapter. Membership for the foundation is $25 a year, and donations support the Scleroderma Foundation's threefold mission of support, education, and research.